one said anything, and I was wondering what the hell's going on. I suppose
now we can hear you.
Generation. Anyway, anyone know Yak Shemesh? What that means? Come on, somebody say something.
Something.
All right, I'll take that. So today we're going to talk about spines. I've been asked specifically to talk about three things. I understand most of you guys are junior doctors or about to become junior doctors, and this is aimed at people who are like, you know, SHO, house officer level, trying to make it into the big time, you know. So these are the few things that you need to know, and your spines will be under control. So, okay, let's go right into it. We're not going to waste time. Equina Syndrome. People shit themselves over this all the time. No pun intended. Tell me, this is the scan of a 38-year-old female, 4 months of back pain and radiating to the right leg. Kai, MCQ1, please. So the following are red flags, true, false. Retention of urine, unilateral leg pain, perineal paresthesia, foot drop, bilateral leg pain. You have 20 seconds. Oh, that sucks. These are true, false, and we've got single best answer options. Okay, kind of makes it pointless. All right. Okay, it looks like most of you got it right. All my MCQs are true, false. That kind of sucks. Anyway, perineal paresthesia, retention of urine are both correct. Unilateral leg pain, bilateral foot drop are not red flags. Bilateral leg pain can be red flag. So I would have accepted that. Okay, so you guys seem to be on the money. I'm good with that, okay? So now, I'm gonna pick on somebody, and then Kai, I want you to unmute them so they can speak. So I'm gonna pick on Jason Osei B ... Your name is too long for my screen. Unmute yourself and open your video and describe this MRI to me, please.
Sorry, hello there.
Jason.
Hi there.
Hi, how are you?
I'm good. You can hear me?
I can hear you very well.
Okay.
I can't see you. I'll take it though. I'm okay with that.
Sorry, I'm outside. That's fine. And I just went to the gym, so
no problem. So look at this MRI scan and tell me what you see here.
It looks like on the left there's little like narrowing of the, I think it's the spinal cord there.
Perfect. There is a narrowing on the left. Indeed, it is a narrowing, but it's on the right side. Are you looking at the axials or the sagittal pictures?
The sagittal.
Very good. So on the sagittal, the L45 disc looks dark, which indicates that it's desiccated, and it looks like it has a bulge. The yellow line at that level indicates that the axial section that you can see on your right, oh, beg your pardon, on your right is a cut at that level. At that level, you can see that the disc, how do I use a pointer here?
The normal cursor should be okay.
Can you see my screen here?
Yes, we can see the cursor on the.
You can see my mouse moving around?
Yes.
Oh, cool. Okay, I didn't realize that. So this is your disc. This is the origin of the L5 nerve root, and you can see that the origin is pinched, okay? So, right, thank you very much, Jason. I'm very glad and grateful that you didn't leave me hanging there. Blair Cooper, you're next up. What symptoms will this patient have?
Hello?
Yes, hello.
Disc bulge at L45 might produce some paresthesia over the medial foot, the dorsal.
Love it. You're going straight into the L5 nerve root dermatome, which is exactly correct. Paresthesia is one of those symptoms. You'll have radicular pain, radicular symptoms. So some symptom related to the nerve root, which in extremis will cause a weakness in the foot, such as a foot drop. Win. That's a pass. So this patient has right-sided leg pain. Now, can somebody tell me whether this MRI scan shows coda-equina compression? Okay, I'm picking someone right now. Eminem. Eminem? All right. Al-Migdad Ali, your turn now. Does this show?
Syed, I can see Isabella Drummond. Go for Isabella Drummond.
Right,
What about
Isabella, okay, Izzy, go. Does this picture show codoequina compression?
Thanks, Lucky. There's not central compression of the cord, so I'd say it's not codoequina.
Fine. Okay, so how do
Hey,
you?
can I speak now?
Who's that?
Al-Migdad Ali?
Yes. Does that
Yeah.
show codoequina compression?
Sorry for that. Just for a codoequina thing, in codoequina we should check the end of the spinal cord itself to see whether it's codoequina or not.
Okay, so right, all right, you've dug yourself a hole, my friend. What is the codoequina?
Oh, sorry for that.
No problem. It's good. Don't worry. This is a good thing. I'm impressed.
Yeah.
You had the balls to answer.
I just mixed it up with the codoequina and the conus
Spinal cord.
medullaris.
You just mixed up the spinal cord with the codoequina. The spinal cord proper ends at L12. Okay, so beneath it is the
Which is the
codoequina.
conus medullaris.
So a codoequina compression in this picture, this is the rootless of the codoequina. So compression of this would indicate a codoequina syndrome.
Yeah,
Okay?
exactly.
This is therefore not showing a codoequina syndrome. So let's say this is just a disc prolapse. Most patients will be fine if you're living for 6 weeks to 6 months. So I've got here a little bit. I'm not gonna insult you guys with basics, but you need to take a history and an examination. You need to find out how it happened, how long it's been going on for, how are the symptoms, where is the pain, and you need to ask about red flags. So next person, Matthew Ferrugia, tell me, red flags of spinal surgery in spines, what are they? Yes. Matthew.
So in terms of history, is, so I said, for codoequina compression, bilateral leg pain.
Okay, bilateral leg pain.
Associated with weakness or paresthesia, bladder or bowel.
Weakness or paresthesia is not a red flag, but I like what you're doing. Bladder, you're about to say, that would be the first thing I say. Carry on.
Bladder retention or incontinence.
Well done. Retention and incontinence. Which one comes first?
Retention.
Why?
Because in codoequina syndrome, it's overflow incontinence. So
very good. Very good. So you lose the autonomic nerve supply to the bladder. You lose bladder tone. You get bladder atonia. The bladder fills up, and you get overflow incontinence. Very good. You've passed. Well done. I'll make that. You also passed. Don't worry. So bilateral neurological deficit, urinary retention, fecal incontinence, saddle paresthesia or anesthesia, and sudden onset of severe central spinal pain can all be concerning features. Now, there are a couple of others. I would need you guys to mention just 2 of them that I want you guys, and then I'll let you move on to the next one. So, Mr. Afolayan, this is a slightly higher level. What are the other red flags?
So other red flags apart from bilateral urinary retention, fecal saddle anesthesia, bilateral sciatica. So, I mean, once the patient, apart from the history, other red flags in terms of clinical examination or just history? Okay, so when you examine the patient, the critical thing for me is when I examine the patient, one, does it confirm the perianal numbness and the anal tone? And importantly, when the patient is catheterized, I'm asking them, can they feel the catheter?
Perfect.
And if the patient, particularly if it's painless and they have a post-void, so if you ever get referred a patient, you have to ask the A&E something very, very specific. Ask them to tell the patient to pee, and if they can, to do a post-void residual. If the patient has more than 200 mils in their bladder, that's a huge, huge red flag, which has been shown to correlate quite highly with potential codoequina.
I was rather thinking in terms of the further history. And in that history, there are 3 more things that I always ask about. History of drug use, history of cancer, and history of fever. Because if there's a fever, they could have epidural abscess. If there's a history of drug use, it could be an epidural abscess. If they have a history of cancer, this could be a metastatic spinal cord compression. So you've got your usual urinary stuff, your bowel stuff, your bilateral leg pain stuff, and cancer, fever, and infection, and IVD, history of drug use and stuff like that. So these are important red flags to remember when you take a history. So, and then there are a few other things: unexplained weight loss, history of cancer, infection. Over 50, under 16, I don't buy it, but some textbooks say it, so I put it in there. Okay, so John, now I'll spare these people who actually have been surprisingly all forthcoming. I was expecting them to all hide behind their phones like Eminem did and didn't speak. A hit rate of a fail rate of 1 out of 6 is actually pretty good. Now, this is the same patient, and this is 12 months later. She called me up to say, Syed, I'm having some issues. And I said, okay, why don't we get a scan done? And we saw this. John, I'd like you to describe this MRI scan, and I want you to now take the other guys through what you would do as a fellow in spinal surgery who's about to become a consultant.
Okay, so this is a sagittal and axial T2 weighted images of this patient's.
And by the way, everybody, if you don't understand something, put it up on the chat. Just unmute yourself and speak, right? So if this was in a lecture theater, you'd raise your hand and speak. I quite like that dynamic. I like the interactive nature of things. Otherwise, I used to fall asleep in lectures routinely, and it's very hard to stay awake or talks like this, but feel free, carry on.
Thank you for that. So, I mean, the concerning thing for me with the symptoms that the patient is presented with and this MRI scan is that at the 4-5 disc level, which is what's represented by the axial, there is a central, slightly right-sided, but more paracentral disc protrusion, which obliteration of essentially most of the space where you'd have the nerve roots.
Yeah.
Right at the back there, that little blush of white that I can see, I think is probably some flavum. So for me, if this patient has symptoms consistent, or has symptoms, this MRI scan together would mean that I would counsel this patient about needing urgent intervention in the way of decompression.
Perfect. So radiologically, Blair and whoever was talking, and Matthew, I believe, this is now a Equina symptom, Equina compression. Now look at the picture on your right, and now compare it to the picture I had before, right? Here you can see cerebrospinal fluid, you can see the nerves in cross-section. 12 months later, you can no longer see them. This patient has got some pins and needles in her private areas. Now, what are we going to do about this? This is a surgical emergency, yeah? You've got about 24 to 48 hours before you lose things. Moreover, it's not as simple as that, because sometimes you have the Equina just being tickled, and it's giving you a warning sign, but it's not yet going to be ruined. That is something important to appreciate, and that's the difference between Equina syndrome impending or Equina syndrome in retention. And the essential difference between the two is that if it's impending, you don't have any frank incontinence, but you have some issues. You might have hesitancy, you might have frequency, you might have some anesthesia, you might have some difficulty voiding, but it's reversible. If you're in frank retention, you've usually missed the boat. So that's a very important distinction to make. What John said earlier on about your post-void residual, he said 200, I'm a little less generous. For me, a post-void residual over 100 is significant. It indicates that the bladder is not voiding. If somebody has your bilateral leg pain or saddle anesthesia, but they don't have a post-void residual of over 100, it doesn't mean they don't have Equina syndrome. It means that they may have impending Equina syndrome. You still treat that urgently. You don't sit around on that. Now, the reality is the majority of patients that come into A&E with bilateral leg pain or severe back pain do not have Equina compression. And they've done studies on this. Some years ago at SBNS, they presented it. They said only about 1 or 2 in 200 referrals turned out to be real Equina compression. But the problem is that it's really difficult to tell without an MRI scan. So you've got to have a clinical diagnosis that's backed up with a radiological diagnosis. So it's first a clinical diagnosis, then backed up with a radiological diagnosis. The clinical diagnosis is not trumped by anything. The radiological diagnosis confirms it. And I say that because I've seen many patients who have scans that look like that, right? Look like this, where radiologically the Equina is completely gone, but they have no symptoms. And there can be many reasons for that. But you have to assume that this is going to be a problem. So there are many causes of Equina compression. Herniated nucleus pulposus or slip disc is common. trauma, cancer, metastatic disease, infection, all of these can be causes of coda-equina compression. Hence, this is reflected in the red flags that we mentioned earlier on. And we've talked about the assessment. The bladder post-void comes up in the clinical assessment. And this is in your examination that you look for bladder voiding, you look for loss of anal tone, you do a PR exam. As with general surgery, if you don't put your finger in, you'll put your foot in, and the usual rubbish that goes with that, okay? So, you know, you need to pay attention to these patients, okay? And in the exam, you look for voluntary contraction, your bladder palpation, bladder scan, post-micturition void, and refer to A&E if you're in the community. Generally, in most places, orthopedics don't take them, neurosurgery takes them, but just refer to your local spinal unit. And if you don't know who it is, call up switchboard and ask for the spinal on call. Okay, so that's coda-equina compression done as a junior doctor. That's all you need to know. If you can blurt out 10 to 20% of what we've talked about, you've passed. Now let's move on to MCQs 3. Sadly, again, Sharmili, this is your fault. I call them true-false MCQs, which does not reflect well in the format of MCQs you're going for. But Kai, let's go for it anyway, and let's see what people say.
Sorry, Mr. Aftab.
Not your fault, don't worry, I didn't realize either. So, CESR and CESI are more or less the same thing. We know that's false. In CESI, the boat has already sailed. In CESR is a clinical emergency. CESI is not a clinical emergency, and a post-void residual over 50 mils is significant. So I want you guys to click on the one which you know is totally true here, where there is no doubt in any of this one. I want you to pick it in the next 5, 4, 3, 2, 1 second. Go. Well done. Perfect. CESR is a clinical emergency. Can we go back to the questions, please? Okay. Questions? Yes. Okay. CESR and CESI are not the same thing. In CESI, the boat has already sailed is incorrect. That's for CESR. CESI is not a clinical emergency. That's incorrect. It is an emergency, and a post-void residual of 50 mils is significant. This, I would actually give it to somebody if they said yes in an exam situation, because it's an indication that you understand that a post-void residual in itself is a significant factor. But I put it in there because it's always good to have crappy MCQ questions that don't have a right or wrong answer. It makes you think and help people fail exams. So,
the question. What
yes.
does FR and SI stand for again?
Coda-equina syndrome or coda-equina compression syndrome impending and coda-equina compression syndrome in retention.
Okay, thank you.
Okay, right, good. Thank you for asking the question. That's a good question, actually. Fine. So management, yeah, I mean, you do your X-ray, you do your bladder scan, you need to get an MRI scan, onward referral, surgery, done. Okay. Now, John, do you want to do the spinal cord injury bit, or do you want me to carry on?
No, we can talk about it. And are you happy to be the clicker?
Yeah.
Right. So spinal cord injury is devastating. And the reason it's devastating is not only because if you miss it in your career, you know, the lawyers will give you a really hard time. But if you imagine what it is for the patient, it's completely and totally devastating. You're talking about physical, psychological, everything is affected. Bladder, bowel, sexual function. And you know, you can see there that in the United States alone, you're talking about 1 million plus patients that are affected. And in the UK, we do see less. Obviously, we're smaller, but we're still talking about 1,000 cases of spinal cord injuries per year, which is something that's published some years ago by one of our previous fellows, now consultant in Romford. And in terms of the presentation, really, it's bimodal, meaning that there's a young group of people that get it. Obviously, the pathology is different. And then there is an older group of people that are getting it. So if we go to the MCQ, can we load that up? Pretty please. And this is the question. So once again, we know that it's a single choice, but in your own mind, obviously you can see which is true or not. So spinal cord injuries, in terms of the statements that are made 1 to 5, The first one goes, once someone has complete spinal cord injury, there's no point in offering urgent surgery. So do you think that's true or not? Spinal cord injury means that it is unlikely that a person will have any meaningful employment or existence. A slightly pessimistic point of view. I want to know if you agree with that. I've probably led you in a certain direction. Then third one, it is better to be able to walk than to win. Sorry, I just heard that question. Or you can read that yourself. There sounds like a question that Mr. Aftab has made up himself. And 4, patients with subsected spinal cord injuries should be given urgent high-dose steroids. And the 5th one, initial trauma is the main cause of spinal cord injuries. So let's take a poll there. There are a few likely answers there, actually. And that's one would not jump at your throat at for clicking. But let's just take a straw poll, and if you click free, well, yeah, private message me and we can talk about it. But okay, so submit your answers in 5 seconds. 5, 4, 3, 2, 1, and let's see what the poll shows.
Someone actually clicked.
Someone, yeah, I bet that's one of my previous SHOs, a joker. I'm sure.
Report this
I'm sure someone just did that just because, just to tickle you, Mr. Aftab.
Thank you.
So,
thank you. I appreciate it.
So I mean, the first one is a loaded question, and it's not true because there are other reasons to offer surgical intervention, which we will talk about later. Of course, number 2 is incorrect. Number 3, someone just pulling out legs clearly. And number 4 is totally correct about high-dose steroids, which we're going to get onto. And the initial trauma is also correct. That is usually the primary cause of the injury. So moving on to the next slide.
4, spinal cord injury and high-dose steroids is controversial. I put that on purpose.
It's controversial, but there is
don't anymore. Okay.
There is a in the paper section, you're going to talk about that, which is coming up. So that's something for you to think about. But that's going to come up. We have a slide on that that's coming up later. There has been a shift, and it's kind of gone full circle on itself, but we will talk about it in due course. Okay, fine.
Yeah.
Next slide, please, Mr. Aftab.
Yes.
That's right. Excellent. So definitions, I'm not going to read everything out there. You can read it yourself. So injury to the cord, we know that the cord extends from the base of the brain down to L1-2. In most people, as Mr. Aftab has said, there are some anatomical variants, of course, and we're talking about motor, sensory, and also autonomic deficits. And when it comes to whether an injury is complete or not, this is really, really important in the initial assessment of a patient, because that not only addresses the urgency, but for the patients and for giving them projecting what they can expect or not, is really useful to have that straight away. So loss of any voluntary movements, anything that is irreversible in terms of sensation, and having gone through that initial period of spinal shock, that is when you can make that to judgments. And looking at what causes spinal cord injuries, back to the previous slide, please, Mr. Aftab. It depends on which part of the world you're in, but in the part of the world that we're in now, we're talking about road traffic accidents, falls, violence, and sports to a certain degree, which is certainly more common in America, and the vast majority are in males. Now, in terms of the types of injury, whether it's primary or secondary, one of the questions that we were asked earlier on is that, yes, the most of the injury happens from the initial insults. That's the primary injury. And then our role as physicians in our understanding the management of the patients is to prevent a phenomenon of secondary injuries. So this is the inflammatory cascade, and that's why there was initially a work for certain medications to reduce inflammation, and just to kind of address things that may be reversible, and certainly to prevent further deterioration from our treatments. So the secondary events, so the cascade of events, as we know from our basic biology, anytime there's an injury, we talk about a zone of injury, there's inflammation. Inflammation is part of the healing process. all those things that are made to learn in medical school, macrophages, T cells, neutrophils, and then the hematoma, the bleeding that takes place, all of these things and inflammatory mediators, they are all important in that initial phase of inflammation. The problem is the spinal cord doesn't tolerate inflammation very, very well. And a lot of times that's because it's within a tight space. And that's what sometimes influences what we do from a surgical point of view. Next slide, please. So assessment is extremely important. Okay, so when we're talking about assessment, we usually talk about triple assessment. And what I mean by that is that you have to take a really good history. And after your good history, you take a good examination. And then the third aspect of that is that you do the necessary investigations, including imaging, to confirm what you're dealing with to allow you to care for that patient properly. So what you want to know in your initial assessment, is this complete, is it incomplete? You have to definitely, a key thing to this is assessing whether the sacral sensation, anal tone is present or not at the time of injury. Unlike every single thing, most of these patients, because they're polytraumatized, is really quite simple in terms of initial assessment, is A, B, C, D. Standard kind of ATLS mantra. And the critical thing on the D side of things, which is the part that involves the spinal cord assessment, is that you must use the Asia chart. I mean, I'm hoping that most of us are familiar with it now. It's universal, is easily accessible, and this is great for communicating within colleagues and also for charting the progression of the patient's neurological improvement or deterioration. So in any assessment that you do, you must involve the Asia chart, and this is what it looks like. I'm hoping that most of us recognize this. And of course, I mean, there's some things that are not there that you need to annotate in the comments section, such as the perianal, the anal tone, for example. But for all intents and purposes, this is complete. And also the nice dots give you an indication of where to perform your sensory examinations if you're not too familiar with it.
Yeah.
Next slide, please.
Bullseye right on the anus.
A bullseye on your anus, you said? Oh, bullseye on my anus.
Whichever way you want to look at it.
All right, Mr. We're in public. So moving on to the clinical assessment. So when you have a formal or spinal cord injury, one of the things that you have to determine is the level. So the level is defined as the last level where the patient has full sensation. And this is really, really important. Just in your assessment, just to know whether things are progressing in terms of secondary hits or not. So documenting whether the patient is tetraplegic, meaning that all four limbs are involved, or paraplegic, which usually means that the lower two limbs are involved. So you then kind of get into this kind of language in which you can basically talk about what's happened to the patient in a comprehensive manner. Next slide, please. So this is more or less saying the same thing. We're all familiar with the MRC grading classifications. There are 6 points. Yes, 6 points on this, because 0 in itself is a score, with 5, which is completely normal. And then moving on to this, we've spoken about complete and incomplete. So I'm not going to labor the points on this again. Tetraplegia is spoken about all 4 being involved. And then paraplegia usually involves
2 legs.
The lower limbs, so to say.
What's a hemiplegia?
So hemiplegia, you tend to see that more in cerebral injuries. So that's half of the side of the body as opposed to half of the body. Leg. Yeah. So literally splitting the sagittal plane.
Tetraplegia, all 4 limbs. Hemiplegia, one side of the body. It took me a while to figure that out.
Yeah. Thanking you. Now, these are the scores that we will put down in terms of the Asia score. So as well as charting things in the Asia chart, what you're able to then do is to give the patient basically a grade, whether it's Asia A, Asia B, all the way down to E. So E is normal. And the big difference here is that A is a complete injury, so meaning...
the way I look at it is A is great, E is fucked, right? And everything else is in between. So if you have a bit of sensory loss, but everything else is fine, you're a B. If you have lots of sensory loss and motor level is okay, more or less, there's a C. If motor function is okay and a lot of the key muscles have gone with loss of grade 3 or less, it's a D, and E is gone, right? So if you just remember A is good, E is bad, and B, C, D is okay, somewhere and in between, that's enough for Frankel's grade. And with the sensory measurements in the Asia score, you're looking at 0, which is absent, 1, abnormal, 2, normal. And it's very simple. And you're looking at light touch and pinprick. Okay, so Asia, light touch and pinprick, your Frankel's grade tells you whether it's A, B, C, D, or E. And then you have to pop your finger into a PR exam and do your sacral segments. And then you get your score, which prognosticates for what this spinal cord injury is going to do. Okay, fine.
Mr. Aftab, sorry, I think just to go back to that Asia classification, I think it probably just came out slightly incorrectly. So the A, just to completeness, is very, very bad, and E is normal. Sorry, I think it came out the other way around.
Oh, no, sorry. Did I say A is good? I meant E is...
I think it may have come out that way, or maybe it's just my speaker.
No, it's my... A is bad, E is good, and everything else is in between. Okay?
That's right. Thanks, sir.
A is bad, okay? It's the opposite of an exam grade. A is bad. Just remember, Frankel, A is bad. Then you won't forget it. Because it's actually not intuitive. Anyway, A is bad.
It's very intuitive. Next slide.
Yeah. Okay, fine, carry on. I don't think we need to go into partial spinal cord syndromes. I think we can skip over this. But suffice it to say, all right, okay, actually, you guys have all been through medical school. I'm going to ask a question. There are some of you, I see. Okay, there are some of you who have not put up a name, and you think you're being clever, but I'm going to identify you. There is a gentleman wearing a light colored tie with a particularly smug expression, which is not a problem, but I will put their picture up on the PowerPoint, and I will identify this individual. And that's the person that I'm going to ask the next question to. So
that was
1 second.
Mustafa.
Huh?
I'm just trying to figure out who you're describing.
Insert photo, insert image, import image. Give me 1 second. I will get there. This is worth it.
If you're that person, just start to speak straight away before Mr. Aftab comes for you. Yeah.
Yes, gotcha. All righty. Okay, almost there. Share screen. Right. This person. Can you guys see my screen?
We can see your screen.
Can you see the person I'm talking about?
It's Mustafa.
Yes, Mustafa. Tell me about Brown-Séquard syndrome. Mustafa Ismail, tell me about Brown-Séquard syndrome. All right, maybe not Mustafa. How about Muhammad Birai? Tell me about Brown-Séquard syndrome. No?
Oh, Shazil. Shaz, tell us about it. I know you know it. Go on. Rescue us.
It's just hemitransection of the cord. So
man,
you get...
What does that mean, though? What does it mean? As in terms of what is hemisection? You know, how do you get hemisection? Number one, and what deficits do you see?
In terms of your deficits, the only things that will decussate will give you contralateral symptoms. So that's your spinothalamic tract, so pain and temperature. Everything else will be ipsilateral deficit. So your motor weakness and your loss of proprioception, so your dorsal columns will be ipsilateral. And then your loss of pain and temperature will be contralateral.
Good man. And Mohammed Birai, you were unmuting yourself. Are you ready to take it to the next level? Why is that? Why do you get that picture?
Okay, I'm listening. Can everyone listen to me?
We can listen to you. Yes, yes.
All right. So why do you get which picture? Sorry.
Tell me about Brown-Séquard syndrome in a cord hemisection. What's the picture that you get? Clinically.
You can get a paraplegia.
Okay. Yeah.
Okay, and I think you can also get a hemiplegia. Am I right or wrong?
Yeah, that is correct. But there's a very characteristic distribution of abnormality. It's okay if you don't know it, man. Don't worry about it. I like the fact that you're going for it.
I don't know the distribution of abnormality, and because I'm doing a master degree in trauma and orthopedics, and unfortunately, I've not reached the spine topics.
Put this young man out of his misery.
Yeah, thank you. Yes.
John, go for it. Tell them the answer.
Yeah, so it's also to do with the kind of decussation of the spinothalamic tracts in comparison to the kind of ipsilateral cortical spinal. So there are different levels in terms of decussation. Hello?
No, he needed to mute himself.
Oh, he needs to mute himself. Yeah, and effectively what happens, and the reason you get contralateral symptoms in terms of the sensory side of things is that, particularly when it comes to pain and temperature, is that the neurons that decussate a level lower than you do with the motor. So that's why you get it. For example, if you have a right-sided lesion, your symptoms will be on the left side. For the motor, it's ipsilateral. And when it comes to pain, when it comes to vibration and proprioception, the posterior column is ipsilateral. So that's why it's all about the anatomy of the spinal cord.
Ipsilateral motor, contralateral pain and
temperature.
Correct. That's Brown Séquard, very characteristic. I saw it once in this chap that got shot in the back when he was running away, and the bullet went in and took out.
It has to go halfway through. Is it, you either get shot or you get a clean knife that stabs you exactly halfway.
Okay, right. I think it's time for an MCQ. I think people are falling asleep. So I'll just take over quickly because we're coming up to the 20 minutes I had allocated for this. You want to make sure that these spinal cord injury patients are looked after properly. You want to do a full workup on them, ATLS protocols, and you want to make sure that they're looked after in an intensive care unit because they have lots of physiological abnormalities as a result of spinal shock, which is loss of sympathetic tone to the venous system and to the cardiovascular system. So you get bradycardia and hypotension. Okay, so these are problem things. You need to keep an eye on these patients carefully. I had an MCQ somewhere in here. Kai, can you put up the next MCQ? Yes. Oh, well done. I like it. Testing bulbocavernosus reflex is awkward and should be avoided. True or false? Complete spinal cord injuries do not recover any function. True or false? And if there is a suspected spinal cord injury, patients must not be moved under any circumstances. True or false? Central cord syndrome has a very poor prognosis. I intentionally didn't ask someone about it because I knew there was an MCQ coming up. And if someone has a cord injury from attempted suicide, this is an indication to offer conservative management only and is a poor prognostic indicator. True or false? You have 10 seconds. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Close. Let's see. Let's see the answers. So, testing is awkward and should be avoided. You knew the answer. Well done. Spinal cord injuries do recover. So, incomplete spinal cord injuries generally have significant improvement, which is the reason why it's important to know it. Also, if it's an incomplete spinal cord injury, it is super important to get the decompression done quickly because it can protect the spinal cord from those secondary effects that John was talking about. If there's a suspected cord injury, patient must not be moved under any circumstances until the spinal surgeon has cleared. This is a trick question. If you're bleeding out and you're dying, forget the spinal cord, save the patient. Don't forget your ATLS first, A, B, C first, D and E. So D is when your spinal cord assessment takes place. So don't forget that. Central cord syndrome does not have a poor prognosis. It has the best prognosis. And 1 year, 50% significantly improve and go back to its normal functioning. And if someone from a cord injury has from attempted suicide, this is an indication to offer conservative management only and a poor prognostic indicator. I put this there because surprisingly, one of my trainers took this view, and I thought that was actually very offensive. Someone trying to kill themselves is a reflection of disease, right? It's a disease. And that's probably not how they are when they're not diseased. So to deny them treatment is wrong. And if you think that way, then you should reconsider your career in medicine. But it is important to actually articulate these things and point them out. Just like having an attitude that winning gold in the Paralympics is not as good as walking is bullshit. I put these in there just to keep context and keep everybody grounded to what is right and what is normal. We have to actively make sure that people understand these things rather than just assume that it's okay and make a joke out of it. So I'm going to skip over the evidence, John, if you don't mind, but suffice it to say that evidence is mixed. In general, early decompression for incomplete injuries, early stabilization for rehabilitation and for protecting the spinal cord, and consideration for steroids seems to be the answer. The steroids is a unit by unit thing. I usually give steroids in a cancer situation or in a spinal cord situation, but it hasn't been shown definitively to give the answers or to make an outcome improvement, because the findings of the initial studies have not been replicated. But then some papers now have found it, and we're going to stick with some of it now in some places. So we don't need to go through this, John. I'm going to skip through this because we've already got time. Now we're going to go straight into spinal trauma. So I'm going to take over trauma. I don't need you guys to understand Doni classification, AO classification, but let's go to the next MCQ, Kai. So, spinal cord injury. Look at the picture that you've got in there. Oh, this is also, all my questions are true, false, but I didn't give you a chance to format this question correctly. Okay, so this patient likely has a stable spinal fracture. Okay, this patient can be managed in a collar. There is no urgency in managing this patient. The only concern for this patient is neurological injury. This patient can be put into a collar and sent home with a virtual fracture clinic appointment. I'm going to just say, if any of you thought any of these options are correct, you really need to go and read a book, like a basic book for like year 1 medical school. Okay, these are joke questions. Okay, next, let's close this rubbish. Don't even look at the poll. I don't want to embarrass people here or myself. Fine. Okay, so classification. There are 2 things I want you to remember. I mean, people go on about flexion, distraction, extraction, rotation, blah, 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 all this rubbish. Forget about it, right? You need to know the Helix classification. That's the thoracolumbar injury classification score. There's the AO Helix, which is a new modification. But there are 3 things you look at. I don't need you to remember the classification, but you need to look at the shape of the fracture. You need to look at the posterior ligamentous complex and the neurological status. I haven't gone into basic anatomy, but the parts of the spine which are at the back, and I'll name them for you so you can remember. Pedicle, posterior vertebral wall, facet joint, spinous process, interspinous ligament. Anything that's behind the vertebral body is the part of the posterior ligamentous complex, right? Anything broken in that means that it is not maintaining its integrity. Or if you palpate someone's back and they're sore, that means the posterior ligamentous complex is injured. So these 3 things tell you what to look at, okay? And you make a score. You look at whether it's a compression type fracture, if it's a burst type fracture, or if it's a rotational or a distracted fracture, right? You look at whether the nerves are intact, whether there's a nerve root involvement, or whether there's a central involvement or a codequina involvement. And you look at whether the posterior ligamentous complex is intact. And you make a score out of 5, out of 8, if this, or out of whatever. If the score is more than 5, you operate. If it is 4, equipoise. If it is less than 4, then you don't operate. So that's basically the Helix classification, which is very well known and validated to be a good way to classify which fracture needs an operation and which one doesn't. And the equivalent is the cervical spine, subaxial injury classification for the cervical spine called the SLIC, okay? It follows similar principles. And we talked about the AO modification. Now, this is what I want to go into. The principles of trauma, I don't need you to look at, oh, this operation needs an anterior fixation, this one needs a posterior fixation, oh, this one can be managed in a brace. I mean, those things are not going to get you into ST3, right? Those things are good. If you start talking about those things, you might be okay. But if you start talking about those things and you miss the basics, they're going to think this person thinks they're a consultant already. They're unsafe. No number for you, my darling. Go away and try again next year. So you don't want to be that person. You want to be the person who says, well, I don't know about the classifications in detail, but I do know that there's a classification score called the Helix, which takes into account 3 factors: shape of the fracture, the ligaments at the back, and the neurological status. And it's the combination of these that help us decide whether or not they need an operation. I personally don't have much experience about what operation to do, and I would generally defer to my regional spinal injury unit, who would then take it. But I would be cognizant of the fact that a spinal cord injury needs to be managed quickly, and it needs to be recognized quickly, and that these patients commonly have other injuries associated with them, and that if we don't protect them, we give them a poorer chance of recovery. You say these things, they'll be saying, please, here's a number, come and work for us, come and work for us. If you start saying, well, I want to do a percutaneous posterior fixation of T9, they say, fuck off, don't come into my operating room. Anyway, principles of spinal surgery, you need to understand are 3, okay? Management of any spine, if you understand these 3 things, you're gonna win. Any spine needs to be decompressed, protect the nerves. Any spine needs to be stabilized, protect the nerves, maintain function, and any spine needs to be rehabilitated. So if you understand these 3 things, then you will understand how to fix a spine. You've identified an unstable spine, you've identified a risk to the nerves, and then how you fix it depends on these 3 things. So you can either fix it from the back through little holes, or you can go from the front, go from the side, you can decompress the nerves, you can do all kinds of things. But you have to be aware that whatever you do is going to damage the patient as well. If you go in from the front and there's an aorta exactly where you need to be, obviously you don't go in there. But that's enough. You don't need to know any more about spinal fractures, okay? Second hit to the spinal cord, protect the patient, ATLS principles, urgent referral. These are things you need to know, okay? So we're going to move straight on to the cases. So I'm going to pick on somebody now, all right? Shaz, unmute, speak. Tell me, what do you see here?
Hi, so this is a lateral of a C-spine. So X-rays are not great in a trauma setting for the C-spine.
Well done, I like it. X-rays are crap. You need a CT scan. But there are some things on this X-ray that should make you worried. What is that thing?
So I'm trying to look at the 4 lines that we normally look at.
I love this guy. You've got it, man. Okay, tell me about the lines.
So you've got, I don't remember the names of them. I'm tracing them out with my cursor.
Exactly. I don't care about names. I care about principles.
The one is the anterior to the vertebral body. 2 is the posterior vertebral body.
So look at the posterior to the vertebral body. Where do you see a problem in that line?
Is there a retrolisthesis at C5, C6?
That's it, man. So if you look at this is C1, 2, 3, 4, 5, 6. So again, you don't have to worry about using retrolisthesis. In fact, this is an anterolisthesis of C5 on C6. When it comes to an interview setting, if you're not sure, don't use the word. Because you could have just said that C5-6 alignment doesn't look right. Why? Because the back of the vertebral body at C5-6 doesn't match up with C6, okay? So what are you going to do next?
So I would, depending on the trauma, I'd make sure this patient managed according to ATLS principles, that their C-spine is immobilized and they get further imaging. So they probably will be getting a pan-CT anyway.
Yeah,
but
okay.
I would also like a MRI of the C-spine.
Slick, man. You get a CT and an MRI scan. So, I mean, this is a bit of a cheat. In the MRI scan, you can see, you could in fact see that on the X-ray, right? You could see that this bone is broken, that disc is ruptured most likely, and there's a malalignment. In the cervical spine, you only need a tiny amount of malalignment to indicate significant instability. This is a very unstable fracture. Usually I would have done a disc in between, but I ended up doing a plate and screws at the back. This patient did very well. Okay. And I wanted proper protect. This patient was neurologically intact. So I wanted to protect the spinal cord and do as little as possible. You could have, some people would have just done it from the front. That, in my view, is insufficient. You need 360 fixation. Okay. But the principles are decompress, which I didn't need to do because the nerves were fine. We protected the nerves, stabilize, which I have, and rehabilitate. If I do a shitty fixation and I put him in a collar for 6 weeks, then I've broken my principle of early rehabilitation. So I'd rather fix 360 with a 2-stage procedure in a fit and healthy individual who can take it, let him get going, and you're good to go. So I was good with that. Now, if you look here, I missed a screw there. That facet was really broken, so I had to go to the one above. So I matched it up with this one over here. So that's why we took two facets at the back, or 2 levels at the back. Right, well done, my friend. So who are we going to pick on next? John, you pick on someone next.
Rem, who's Rem? I was going to pick on Shaz. Shaz is my boy, but he's already come through. So Rem.
He's done well.
No, he has done really well. Reem.
Hello.
Hey, how are you?
I apologize for my friend's inability to pronounce the name. Sorry about that.
That's okay.
You got a 14-year-old.
2 E's is usually E rather than A, but well done, John. You don't need to read to be a spinal surgeon, it seems. Carry on.
40-year-old lady assaulted by a disgruntled person.
Husband, just say it.
Mr. Yeah, hopefully you didn't give not similar to the last case. So once again, talk me through your thought process of how you'd assess this patient, please, and tell me what you see in the X-ray.
Assess the patient using A to E, of course, and because I'm suspecting a neck injury, I would avoid moving the neck initially. And yeah, so I'll do an A to E on this patient, focusing on seeing if this patient has any sort of basal skull fracture or evidence of bleeding or any CSF fluid leak.
Okay.
And then having a look at the X-ray.
Yes.
So just bear with me 1 second.
Sure. Take your time.
So is there a fracture between C 1, 2, 3, 4, 5, and 6?
So what do you see there? And what's making you suspect an injury there?
Because the vertebral bodies are not at the same level.
That's fine. They're not aligned, and that's what you need to say.
Move on
Yeah.
to the next picture.
That's right.
Now, why is this not the same as the last case? Why was this one managed so differently from how the last one was? Because the last one was also a C5-6 fracture. What do you see here on this MRI Ring? We'll stick with you for the moment. You're doing well.
So I'm just looking at the MRI now.
Yeah.
Could you give me a hint?
No.
I'll give you a hint. Go on.
Look at the spinal cord.
There's good and bad cop here. Is the problem at one level or more than one level? That's my good cop.
More than one level.
Correct.
Okay, good. Okay, we're gonna spare you misery. Don't give him the answer yet. Who wants to volunteer an answer? I'm sure there are some like proper geeks there who are just dying to answer this question. I would be one of those at uni. Don't worry.
It's different because your cord is there's neurological compromise there, and there's signal change in the spinal cord.
Yes. Is that Michael W?
No, it's Shaz.
Shaz again. Come on, man. You've had your turn. Pipe down. Give
Yeah,
someone else.
I heard geek, and I thought.
Yeah. Okay, fine. You're right. There is a spinal. Look at the spinal cord here. It looks completely off, and it's squashed by that disc. There's an injury here. So this patient would have had a pre-existing spinal stenosis that they were coping with, unlike this patient where the spinal cord is all nice and hunky-dory, yeah? And now what they're getting is a proper spinal cord compression. So what this patient has had is a multi-level laminectomy at the back. And you can see evidence by the lack of the spinous processes. Look, spinous process. Oh, where's it gone? Spinous process. So they've had a 4 or 5 level laminectomy. And because they've had a big decompression done, it's destabilized them. You fix it all from the back, okay? So that's a different pathology entirely. Fine, all right. So this is a 53-year-old patient. All right, who's going to take this one? Man Duong.
Yeah. I can try, but I'm not really sure.
Huh?
The picture is not really well.
Very good. You don't have the right pictures here to make a decision.
Yeah.
This is a crappy X-ray.
Right.
First thing to say is, I can't see Jack in this picture. Get me better pictures and get me a CT scan. Absolutely right answer. That's what I wanted you to say. So here we go.
Okay.
I mean, obviously, there's a bit of a cheat here, but there's a CT scan. Without looking at the answer, describe the answer for me. Describe the injury. It's a bit tricky, that one. I'll take you through it. Okay. There's L54321, T12 or L1, whichever way you look at it. T12 fracture of the superior end plate. We've said already that the posterior ligamentous complex includes the facet joints, the spinous process, and anything behind the vertebral body, right? Oh, sorry. So this is the back of the vertebral body. If you look at overlapping facets here, that's normal overlap, that's normal overlap, that's normal overlap. This is not normal overlap. Can you appreciate that? This bit needs to be sitting there nicely. Yeah. So that can you guys see that? Are you looking? Can you see my mouse?
Yes, we can.
Yeah.
We
Okay.
can.
So therefore, the posterior ligamentous complex here is gone. The Helix score on this patient with this compression type fracture with an ligamentous injury and no neurological abnormality is significant. It's 5 or over. This patient needs an operation, right? So we did, and this was actually one of the robotic cases, I believe. This was a percutaneous percutaneous fixation from the back just to stabilize it and then get the patient going.
And just on the MR there, can you just wave your mouse over where you can see the high signal within the posterior ligamentous complex?
Okay, so there you go. This is the fracture, and that's the high signal on the stir sequence in the ligaments. But I didn't need an MRI to say that the ligaments are gone because I could see it here. In fact, when they were insisting on getting this MRI scan done, I said, why do you need to do it? We know it's broken. But I was like, whatever, you guys want to waste some of my tax money, you can do it. I have no issues with that. Okay, but it's good. I prefer more MRIs than less. Don't get me wrong. I was just being facetious about that. So
this is a great case.
Yeah. This is okay. So don't tell them the answer, John. Let someone take you through it.
Okay.
Pick somebody.
So the context, if you didn't see it before, is polytrauma patient from the 3rd floor, pushed or jumped. No one knows really. And this is what you're looking at. So someone should just start talking this through.
Sun Yu Kwan, you're up.
Hello, can everyone hear me?
Yes.
Hello, so this is a sagittal view of MRI scan. I think this is a T1 view. So I can see a significant displacement of the vertebra that is compressing the spinal cord at the thoracolumbar area.
Yeah.
And also I can see there are basically a significant compression of the spinal cord on the axial view as well. So I think I would manage this patient as from the background. This patient is polytrauma. I would manage this patient according to A to E principle, and I will focusing on D by ensuring patient is neurologically fully assessed with history and examination, also with Asia chart as well. And I'll refer to spinal surgeons.
Very good. John, what do you think of that?
Yeah, that was really good. I mean, the only thing I pick you up on semantics is you said T1 for the MRI scan, and I you know, I know, but it's actually.
Sorry about it.
Yeah, no, but apart from that, in terms of what you said is completely right. All these patients, clearly a high energy injury, ATLS approach, A, B, C, D, as you know, the patient is going to have other injuries. And this is the classic one, actually. Just as you've said, because Mr. Aftab and the rest of the team couldn't operate on this patient for a week and a half, whilst the other surgeons sorted out the respiratory problems and all the other injuries that the patient had to make the patient ready for this devastating injury. And just a question, what do you think the neurological status of this patient is going to be?
Since this patient has got significant compression of the spinal cord.
So what I want you to do is
trace out the spinal cord. Sorry, John.
Yeah, that's it. No, that's what I was gonna say. Trace out, basically trace out the spinal cord from one end, from the top to the bottom, and see if it connects. Is a clue.
Sorry, just bear with me. I just need to.
Sure.
I think it's around T9, T10 level.
Forget the numbers, man. Forget the numbers. What's happening to the spinal cord?
Is it joined? Is it one long piece of string?
No, it's totally transected. So
that's all we wanted to hear.
So yeah. I think the patient definitely will be affected in terms of motor function and sensory. So motor function, I would suspect the patient would be paraplegic, would be affecting the lower limb function, and also with loss of the whole sensory function of the bilateral lower limb as well. And maybe potentially that will affect autonomic function, including bladder and also bowel incontinence.
Listen, the point that John's getting to is the fact that this spinal cord is severed. So Between Asia A and E, which one is this one going to be?
This one will be A.
Yeah, because A is bad, right? So this spinal cord is gone. It's finished, right? It's physically disconnected. And so far, we can't reconnect spinal cord. So this patient's going to have a complete injury. Now, what are the 3 principles of management we've talked about in all spines?
So it would be decompression, stabilize, and rehabilitate.
So is there any point in decompressing this patient? What are you trying to protect by decompressing?
I think it would be very tricky to
It'll be pointless to decompress because you're not treating the second hit. You're not protecting the spinal cord from further injury. This spinal cord is severed, okay? So this does not fit in with what we've been talking about so far, because so far it's all about compression, inflammation, hematoma formation. This is severed, right? So here, a formal decompression probably will not help. Here, you want to stabilize to rehabilitate. Okay, so my personal take is I would not bother decompressing this. I would stabilize to rehabilitate. But this patient would have died from their hemothorax, from their aortic injury, from all the other things first, which was fixed by all the other guys first, and then we came back and managed the spine. So you're doing very well. We're going to stick with you for a few moments. How would you fix this injury?
I think as you said, that there's no point for decompression. So first of all, and then of course this injury needs to be stabilized immediately.
How could you stabilize it? I don't need you to know what the stabilization techniques are. Use your intuition. How could this be stabilized? If you were the first human being, and this was the second human being, and this was the fracture, and you had everything that human beings in the future will have invented at your disposal, right? But you don't have the knowledge. Using your brain, how would you fix this? What would you want to do to this fracture to fix it?
I think I would probably use a spinal fusion.
Yeah, okay, you'd want to fuse the spine. Forget about spinal fusion. You're still trying to think about what you would say, what your consultant would tell you in a firm. Forget that. What needs to happen here? The spine is not in connection with each other. The top half of the body is disconnected from the second half of the body. So what do you need to do?
Reconnect.
You need to reconnect it. You need to realign the spine. How can you do that? How do you realign something?
So you
get control of the fragments on
it.
either side and manipulate them into a good position. So you can put something to hold the top end and something to hold the bottom end, right? And put them back in connection with each other and then fix it. You could either put in metalwork, you could put in cement, you could put in glue, you could put in a brace, all kinds of things, okay? Those are the basic principles of fracture management, or basic mechanical principles of putting in. When you broke a teapot, what did you do? When you were a kid, if you ever broke a bit of a ceramic, what would you do?
Run.
Huh?
I said run.
You glue it back together, right?
Absolutely.
You get the pieces, they're like a jigsaw puzzle, fit it back together, and you glue it back together, or you put tape on it or something. So you realign it and you fix it, right? This is the same thing we do in orthopedics, right? You realign things and you fix them. So realign the spine, put in screws from the back of the spine through the pedicle, and then fix it. Here now you can no longer see where the fracture is, but it's reunited. While that looks pretty, this patient is still in trouble. They've got a complete spinal cord injury. But their life is not ruined, because they still have their hands, they still have their arms, and they can still they can still get by in a wheelchair. They can have a successful, meaningful career in almost any specialty they choose. It's actually not as bad as you think, but it takes at least 1 year to get into some kind of normality, and your life is never the same. No matter what people say, it is still a catastrophe. If this happened to me, it would be a catastrophe. I don't want this to happen to me, no matter what people say, okay? Fine, okay, we've done that one to death. Next case, I'm gonna pick on Natalie M, because you have a picture up. Natalie, talk to me about this X-ray, about this scan.
Just to give you a background, whilst you're thinking about it, Natalie, 45-year-old man, known to have cancer of the lung, actually, and struggling in terms of movement and function in his lower limbs, and also numbness down below, presented. And this is the scan that someone has shown you. So what do you think?
I think Natalie is not a real person. She's logged on to get the CPD points and has gone off to party somewhere. Let's move on to Jeremiah Choji. Jeremiah, tell me, what does this show?
Yeah.
Yes. Jeremiah, your sound is very poor, so I'm going to cut you off now, but thank you for paying attention. Well done. Let's go to one more person. Kat Anderson, tell me about what the MRI scan shows.
Hello. This is a sagittal MRI of the spine, and I can see a gross enlargement of the spinal cord between L1 and L3.
Very good. Don't commit yourself to a spinal cord. Say that there is some kind of intracanal lesion. Okay?
Okay. Yep.
Fine. Okay, John, go. Take it away. Keep going. You're doing very well. You've identified it straight away. Carry on. You've passed. Okay, carry on. What are you going to do next?
Well, I guess the same principles apply. So we want to know what the neurological status of this patient is.
John, give her some answers.
Yeah, so Kat, you're doing really well. So, I mean, the first thing when you see this and the patient has triple assessment always, that will always get you out of jail. You take a full history. Personally, in this history, has any history of cancer? So what type of cancer, what treatment has the patient had before? Have they had any back pathology in the past requiring radiation, chemotherapy? You want to know every single thing. Life expectancy from the oncologist that they may already be under is critical. And of course, when it comes to examination, Asia, everything, you have to know the level of deficit that the patient has. And then you need more information. So investigation, this is a CT, this is an MRI scan. And next, if the patient doesn't have it, you need to know CT chest abdo-pelvis to know how far and how bad is this badness in relation to the rest of the body. And in this particular case, the patient once again was deemed to have a reasonable life expectancy, and I said that the primary cancer was lung. This was deemed actually to be a metastatic spinal cord compression, but it's quite a bad one from the posterior elements kind of extending and involved.
Has this patient had previous surgery?
Pardon?
Has this patient had previous surgery?
Not well. It looked like the patient has had a previous decompression and then this recurred, but this is the only image I could find. You can see the little clue from the back.
It doesn't look like those. Looks like
no. You can see so this one was decompressed and then came back. So this is one of those kind of really, really horrible ones. And this particular patient, actually, for the second time round, it was deemed that the patient's life expectancy and what it took was too challenging. So this patient did not have further intervention, but this is just an example of a really nasty injury or nasty compression that involved the spinal cord.
Good. Well done. We got a couple more. This is, it's already 8:15. You guys are falling asleep. We'll just
why don't we cut to so if this is much the same as the other one, but one had surgery, you can see there, I'm sure you can understand that this is a nasty tumor compressing the spinal cord right at the top. If you scroll forward, let's do one. Okay, let's do this one. Yeah. So yeah, so there is a clue already in this. Mr. Aftab has discussed this ad nauseum, so I know someone's volunteered to take us through this. 42-year-old man who's normally fit and well, acute on chronic back pain, but for a couple of weeks now, he's found that his erections are poor. He can't feel himself when he wipes himself. He's got pain going down both legs. You know, his wife told him that he'd literally come and get it checked out. He has to, struggling to walk, and he's coming in. And this is what you see. So how do you want to approach this patient?
Ana Hurtado. Ana Hurtado, you're up. Fake.
Matthew Farugai. Farugai.
Oh, he's already had a go.
Has he? Oh, sorry.
Yeah. Okay, Pavan Kumar
I don't mind having a
Patel.
go. I don't mind having a go.
All right, let's do it. Go for it.
So I would take a history first and foremost, examine the patient and calculate an Asia score. I want to get a bladder scan to make sure the residual is not more than-
Okay, when you say that, let me just give you a top tip, right? Rather than saying it like a medical student of I'll take it, tell me what the pertinent things. So in the examination, what are you looking for?
So in the examination, I'm looking for duration of symptoms. Are they
examination?
Oh, sorry, examination. So I'm looking for low size of lower motor neuron signs, urinary retention, saddle anesthesia, the red flags for a cauda equina, essentially. I'm looking for weakness and deficits in sensation, which would correlate with the levels of disease that I'm seeing in the MRI, so in particular L4, L5, L3, L4.
Will you put your finger on it?
I wouldn't put my finger in. As in what? Sorry, not quite sure. I'd also do a PR exam, and I'd want to check the tone. Yeah.
Okay. All right. Keep going. You're doing well. Yeah. So yeah, you do a district examination, which confirms that the patient has poor anal tone, and sensation in the perianal region is markedly reduced. So what do you think?
Okay. So I'm thinking cauda equina. I'd want to get a bladder scan to work out if he's in retention, or if he's got if he's in retention, or if it's incomplete.
So the patient is not in retention, and you see the scan, and you are Mr. Aftab's registrar, and he's on call. You are going to call him, and what are you going to tell him? Because he can't see the scan.
So I'm going to tell him that there's a patient downstairs who I'm quite concerned about. He's normally fit and well, and his scan shows multi-level disc disease, specifically at L4, L5, L3, L4, L2, L3, and there is possible cauda equina, I think, at the L4, L5 region.
So Mr. Aftab is like, oh man, are you sure? I'm about to kind of, have a glass of wine. It's 5 p.m. Do I need to come in? Do you mean to do this tonight?
I tell him to probably put down that glass of wine, maybe have it after the operation.
But why? Why do you think there's cauda equina compression syndrome? What are you going to tell me that's going to make me think I can't have this glass of wine?
So it's the patient's.
Okay, so this is it, right? It's good. Your answers are correct. They're safe. Yes, don't have the glass of wine. But I'm also thinking, all right, now let's see if this really is a cauda equina, because this guy's going to come and I'm going to interview him for a job. So you got to make sure that you don't look like a dick either, right? So what are you going to tell me over the phone that has made you decide to ask me not to have my glass of wine?
The patient's symptoms clinically, and also the bladder scan result.
So you're talking to me on the phone. What are you going to tell me?
The scanning, the patient's symptoms are inconsistent with cauda equina syndrome, and also it's proven on the scan to an MRI, which is the gold standard, and the patient maybe has
so
some
you're going to
retention.
say that he has a bladder scan done, and there's a post-void residual of however much. He has significant perineal symptoms, and he's having difficulty voiding for the last couple of weeks, and the MRI scan shows that there is significant compression from the discs, from degenerate discs at that level. I think he is suffering from a cauda equina compression syndrome of some description. I think it is a CASI. I think he requires an urgent decompression, and I think it's worthwhile considering doing him tonight. Then you've said it, okay? And then I'll be like, yeah, actually, this guy has made very sensible comments about this patient. He's painted a picture of a patient who needs something done urgently. I agree with that. He's made it easy for me to make the decision. I'm going to go in and do the operation. If you're a senior trainee, I would say, can you do the operation, and offer you the option of doing it, and I would come and let you do it, but only if you give me a good answer that's sensible. With these things, you earn the right to do the surgery. If you demonstrate an understanding of the pathology, and if you demonstrate that you understand what the problem is, then the next level is to solve the problem. If you show no comprehension or no willingness or ability to understand what the problem is, except, doc, I got a problem. You got to calm down. I can't deal with it in there. Yeah, forget about it. You're not going to do the operation. You're going to be the dog's body writing the notes. So you have to think about your training as well. I know we're living in an era where these things shouldn't make a big difference, but they do, because human interactions are still human interactions. And you can do yourself a favor by sounding intelligent, considering things before you make a decision, and always being safe, right? So there's a balance in training. And if you can demonstrate that balance, and if you come across as an individual who understands that balance, is backed up with a basic level of intelligence and a huge amount of willingness, you will be able to achieve whatever you want to in life, if not surgery. And on that note, I'm going to end this talk because it's 20 past 8 o'clock. Any questions?
I'm sorry. Can I ask 2 questions really quickly, if you don't mind?
Yeah.
One, in terms of spinal fractures, when do you do an MRI? So if you're looking at posterior elements and helix, you have to do it every time. But for example, for like an osteoporotic wedge fracture, you're not going to do an MRI.
Yeah.
So when do you do an MRI?
So many neurosurgeons take the view that they have to get an MRI scan every time, and then someone says, "Oh, the patient's got a pacemaker," and they say, "Well, if they don't have an MRI, I'm not going to see them." Computer says no is never a good attitude in medicine. So it's case by case. I have a low threshold to MRI. Low threshold, if there's a neurological injury, definitely MRI. If there's a doubt about the posterior ligaments complex, definitely MRI. If I cannot examine neurology and I want to establish a baseline so that I know what I'm dealing with, let's say the patient's a polytrauma and tube, definitely get an MRI. Generally, if you do MRI, you won't be wrong, but you might delay treatment and you might cause significant problems for the referrer. So you have to be sensible about it. Okay. Basically, neurological involvement, MRI scan every time.
Okay, thanks. I can ask one last question quickly. When do you decide to stabilize? So how much decompression is too much decompression that you want to stabilize?
As a rule of thumb, medial third of the facet joint, you can take it. Some people say you can take a whole facet joint. My experience has been that if I take half of a facet joint, I'm generally okay.
Okay, thank you.
Good questions. In an elective situation with a decompression, you hardly ever need to decompress and fuse unless there's a deformity. Okay. In a non-trauma situation. Any other questions? It doesn't have to be spine related. Did I have any more MCQs, Kai?
No.
I can't see any.
Is that what you said? Any more slides you said?
No, we don't have any more slides. I know that, but I think I wrote 7 questions, 7 MCQs. Okay, yeah, there is one. Good. Okay, let's do this one. X-rays are good enough to rule out spinal fractures. True, false? CT scans will rule out all fractures. True or false? It is common for people to have more than one broken bone in the spine, but they will always be next to each other, or they will be next to each other. True or false? Most spinal fractures do not require surgical fixation. True or false? Only orthopedic surgeon knows how to properly manage spinal fractures. True or false? Neurosurgeons do not do spinal surgery well. True or false? Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Close. Let's see the answers. X-rays are good enough to rule out spinal fractures. False. Correct. That's the right answer. CTs will rule out all fractures. No, they will not. Sometimes it's undisplaced and need an MRI scan. It is common for people to have more than one broken bone in the spine, but they will be next to each other always. Correct. You guys got it. There's a 15 to 20% chance of a non-contiguous fracture, which is the reason why in a trauma situation, some kind of whole spine 3-dimensional cross-sectional imaging is required, either CT or MRI scans. Most spinal fractures do not require stabilization. Correct. If you have a transverse process fracture or a wedge fracture or an osteoporotic fracture, they usually don't need fixation. Only orthopedic surgeons know how to properly manage spinal fractures. That is sadly true. And neurosurgeons do not do spinal surgery well. You guys have got these 2 answers completely wrong. These are 5 and 6 are both true. Okay, well, thank you very much. Thanks for paying attention. Thank you, Kai, for organizing this. Thank you, Shamli, for getting us involved. Thank you, John, for getting involved. Thank you, Lakshmana, for providing oversight, and good night.